in December in Riyadh, and hopefully you will be able to meet us. Thank you very much for your attention.
Many for nice presentation, and we are still dealing with the problems of hemodialysis access, and will tell us about his solution for patients with exhausted upper limb dialysis access.
Assalamu alaikum. First of all, I'd like to thank Professor Dr. Musad Sliman and Dr. Mahsoud Murad for your kind invitation. My talk will be about straight lateral thigh femoral femoral arteriovenous graft as an alternative vascular access for patients with exhausted upper limb dialysis access. I have no disclosure. As we know, the durability of the hemodialysis vascular access remains a troublesome issue for patients as well as vascular surgeons that requires frequent re-intervention to maintain the access function. Lower limb is increasingly utilized as an alternative hemodialysis access site to preserve long-term vascular access and minimize catheter insertion into neck veins. However, it's often reluctantly considered a choice as many nephrologists are lacking of clinical experience how to deal with this access. Inadequate data in the literature, fear of complications such as graft failure, chronic venous insufficiency with compartmental syndrome, infection, and amputation. The aim of our study to report short-term and medium-term outcome of straight lateral thigh AV graft that is uncommonly performed technique as an alternative to loop thigh AV graft in patients with exhausted proximal central veins and upper extremities dialysis access. Our study was single-center retrospective experience of prospectively collected data of 30 patients. It was done between 2016 and 2018. 47 patients with exhausted upper extremities access options were offered a thigh vascular AV graft either in classic thigh loop graft pattern or our modified straight pattern technique due to proximal central venous exhaustion, and were maintaining dialysis on distal central veins femoral vein catheter. All of 30 patients in whom a straight lateral thigh AV graft was constructed and were fulfilling the inclusion criteria completed 30 months follow-up period. Exclusion criteria were patients with peripheral arterial insufficiency diagnosed and detected by duplex ultrasound evaluation or who underwent revascularization with bypass or endovascular therapy were excluded. Those who had a hostile groin with surgical scars due to previous surgery or irradiation, total iliac vein occlusion due to previous deep venous thrombosis or venous outflow obstruction that couldn't be recanalized endovascularly, lymphedema, and those patients were excluded and offered arterial loop graft. Study endpoint were primary outcome, efficacy, and patency. We define primary patency as the time following procedure until next access thrombosis or repeated intervention end with treatment of a lesion anywhere within the access circuit, while the efficacy was defined as efficient dialysis sessions without any evidence of graft malfunction, including low blood flow, high venous pressure, lower extremity pain or swelling, puncture site excessive bleeding, average hemostasis time with digital manual compression of puncture site, and low urea reduction ratio. Patient characteristic, as we see here, general characteristic regarding risk factors, clinical characteristic including duration of dialysis, number of previous access, whatever AV fistula or AV graft, non-tunneled catheter inserted in patient and tunneled catheters. Procedure characteristics, the inflow artery was distal SFA and popliteal artery segment in all of our patients. Outflow vein was femoral vein in 21 patients, while saphenofemoral junction was in 9 patients. Intraoperative venography was done to assess outflow lesion. We found common and external iliac stenosis in 3 patients, external iliac lesion in 4 patients, no finding in 23 patients. Adjunctive procedures done in 7 patients in the form of iliac vein angioplasty and stenting iliac vein angioplasty alone. The preoperative and postoperative ankle brachial index, no significant change in our patient. This is our procedures. All patients were operated under regional regional anesthesia, either spinal or epidural anesthesia. After giving the informed consent, prophylactic antibiotic were given preoperatively. The patient position was supine with abducted hip and slightly flexed knee position to access the medial aspect of the thigh. The outflow venous segment was exposed through 8 to 9 centimeter longitudinal groin incision to achieve exposure of saphenofemoral junction, common femoral vein, and femoral vein. Another incision to expose the inflow arterial segment was done along the lower side medially over the anterior border of sartorius muscle. 50 centimeter length flexing graft, which is 3-layer PTFE, was inserted and tunneled along the lateral aspect of the thigh. An adjunctive iliac vein outflow assessment was done routinely in all patients, and the finding was, and we did iliac vein angioplasty due to localized iliac vein stenosis was performed in 2 patients, and venous stent was deployed in other 5 patients due to extensive involvement of common and external iliac vein or tight external iliac stenosis. The result, all patients with patent graft had adequate efficient dialysis session according to our definition. The patent graft showed a median flow rate of 1,280 millimeter per minute measured by Doppler ultrasound, which was excellent graft flow providing high quality hemodialysis. The most common complication in our study was thrombosis, which was in 12 patients. Lower extremity threatening complication nil, mortality nil. Secondary procedure done in 17 patients, which was 60% of our patients, in the form of ligation and removal of the graft for treatment of infection and rupture. Thrombectomy alone for thrombosed graft, thrombectomy and arterial anastomotic site angioplasty, thrombectomy and iliac vein angioplasty with or without stenting, thrombectomy and venous anastomotic site angioplasty. And this is image of how to manage our complications. Our 6 months primary patency was 100%. It declined to 93% at 12 months, 73% at 18 months, 47% at 24 months, and 40% at 30 months. The secondary patency rate were 97%, 83%, 73% consequently at 18, 24, and 30 months respectively. In our study, obesity represented 50% of studied patients. However, it didn't significantly impact patency directly or indirectly. Limitation of our study, it was retrospective analysis. However, the access procedure with related interventions and complicated were documented in a real time, making us confident of our data accuracy. It was a single center study with a small number of patients, and result not be generalized to other vascular access centers or access procedures. So our next step will be studying these procedures in comparison to other thigh dialysis access technique alone or in collaboration with other centers. Conclusion: lateral straight side PTFE AV graft is a reliable and durable alternative modality with adequate dialysis efficacy in patients with exhausted upper extremity dialysis access. Secondary procedures due complications were frequent, but no significant major bleeding as regard patient with rupture of the graft were non-significant, and no distal threatening ischemia or related deaths were observed. We thought that straight configuration at lateral thigh neutralize many factors affecting graft patency by decreasing graft infection risk factors like obesity, avoiding prolonged groin exposure, avoiding dissection through lymphatic tissues over common femoral artery and vein, by modification of both inflow and outflow in our cases. Paying more attention to detect iliac vein culprit region has a positive outcome on durability of our technique in patients who was previously excluded from such therapeutic options. Finally, in the era of advanced endovascular technique and introduction of a new solution like new device, lower limb dialysis access may not an appealing option for many dialysis access surgeons or nephrologists. However, we think it is still a valuable alternative surgical option in patients had exhausted upper arm access with limited resources, or even in patients with Khairy device complication. Thank you.